Good afternoon, everyone, and good morning to those who are joining us from our time zone. This is Olivia Marquez, and I'm a research coordinator with Health Evidence, and I'm also the research coordinator for the KTA Cancer Prevention Study. It is my pleasure today to welcome you to our monthly webinar series. So that's a welcome to those who are joining as regular Health Evidence users and those who are joining as a part of the KTA Cancer Prevention Study. Today, we will be discussing peer-led interventions to prevent tobacco, alcohol, and/or drug use among young people. What's the evidence? So throughout the session today, we will be posting polling questions through WebEx. Your participation in the polling questions is voluntary and anonymous, and we found and hope that this enables engagement and stimulates discussion throughout the session. Just to let everyone know that after today, the PowerPoint presentation and the audio recording will be made available through the Health Evidence SlideShare account and through our YouTube account. So the links to those resources will be posted in the chat section in WebEx. And today we will be featuring the review in Health Evidence, peer-led interventions to prevent tobacco, alcohol, and/or drug use among young people aged 11 to 21 years. The links to this systematic review and to the Health Evidence Quality Appraisal will be posted in the chat section. So just a few housekeeping items before we begin today. Please use the Q&A and chat in WebEx to post your questions or comments. We ask that you please send your questions or comments to all participants and not just to the host, but if you do so, not a problem, we will still see your question or comment. Towards the end of the session, we'll open up the webinar for open Q&A, and I'll be able to read aloud any questions you have to our presenter. You do not need to wait until the end of the session to post your questions. You can do so as we are going through today. So for the best connection, we recommend that you use a wired internet connection versus wireless. And should you have any issues connecting, the WebEx 24/7 helpline is posted on the slide, and that will also be posted in the chat section. So for your audio today, please listen through your speakers, and you can click Communicate Audio Broadcast at the top in WebEx to hear us today. So we'll start with our first polling question, and we'll open that up in just a few moments. And we just want to get an idea of how many people are watching today's session with you. If you could just let us know, answer the question in the polling section on WebEx, and remember to click Submit when you're finished. So thank you to those who are responding with us. We see most people are joining themselves, and we have quite a few people who are joining with 2 or 3 people with them, and a few with 4 to 5, and even 6 to 10. So it's great to see that we have groups joining us today. So a special thanks to our Health Evidence team who has brought together this session today. There's a large team of us who help to work to keep Health Evidence current and maintained, as well as coordinate our monthly webinar series. So for those of you who may be unfamiliar, Health Evidence launched in 2005, and we're a comprehensive registry of reviews evaluating the effectiveness of public health and health promotion interventions. We provide over 90,000 visitors per year access to over 4,800 quality-rated systematic reviews. We provide links to the full text, plain language summaries, and webinars where they're available. One of our main goals of Health Evidence, in addition to making evidence on the effectiveness of public health interventions more accessible, is to make it easier for professionals to use evidence in decision-making. So the value added for Health Evidence is that we help to save you time. We have done the work to screen and appraise each review within our registry. We screen all reviews for relevance to public health and keep our repository up to date by constantly screening relevant databases. At any given time, we're no more than 1 to 2 months behind a publication date. We have done the work for you by critically appraising all reviews through a transparent process, whereby you can actually click on the full quality assessment for each review and see our rating for each of our 10 assessment criteria for each review. Healthevidence.org also has various tools and supports for EIDM available online. And many users have informed us over the years that our tools and repository are easy and simple to use. So I just have on the slide here a model for evidence-informed public health, which consists of 5 components that you can see in the diagram. So traditionally, public health practitioners and decision makers consider evidence about community health issues and local context, existing resources, and community and political climate when making decisions about program and policies. However, it's become more apparent that considering evidence about research may be more challenging. As such, the Health Evidence webinar series is designed to identify research evidence relevant to public health decisions and present those to you today via author-led webinars. So the evidence-informed public health wheel that's shown here illustrates the steps that are involved in evidence-informed practice. So the wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence in the decision-making process. So there are 7 steps in this wheel, and today we'll actually hear about how our presenter has worked through the first 4 steps in order to help with decision-making with the remainder of these 7 steps. So we have our second polling question to make live here. Have you ever heard of PICO-S before? And again, thank you to those who are responding. Just make sure to hit submit at the bottom. So far we have almost a 50-50 split between those who are familiar and those who are unfamiliar with PICO-S. So I'll give a chance for those to continue to respond, and in the meantime, we'll move on to our next slide. So PICO-S is a way for you to structure your questions in a defined set of evidence-informed decision-making. And it involves defining who the population is that you are interested in, what the intervention is you want to know about, the comparison group, if any, and the specific outcomes that you're looking for. Sometimes we also have a particular setting in mind, which could be school or community setting, for example. The value of a PICO question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which allows you to further articulate specific components of the question that help you to hone in on your research question that you want to search for. In this way, searching for relevant information relevant to your PICO should then be quicker and easier. So before we get started today, we're wondering how often you use systematic reviews to inform a program or service. So always, often, sometimes, never, or you may not be familiar with what a systematic review is, and that's completely fine. Today we'll hopefully enlighten what this process is. So thank you to those who are responding. We see that so far, most people who are responding often use systematic reviews. And next we have sometimes, a few never, and a few are unfamiliar with what a systematic review is. So that's great. Today will hopefully help to shine light on a little bit more information about what this process is. So today we are very pleased and excited to have Dr. Georgie MacArthur join us today to present her systematic review findings. And she's joining us from the National Institute for Health Research at the University of Bristol. So we have just one final polling question before Georgie gets into the findings of the systematic review. And we're wondering, so before you hear about the findings from the review, your opinion of peer-led interventions reduce the odds of youth tobacco smoking, alcohol use, and cannabis use. So wondering if you strongly agree, if you're neutral, disagree, or strongly disagree. So we see so far that we have most people are agree or strongly agree. So with that said, it is my pleasure to bring Dr. Georgie MacArthur in to present the findings of her review. Thank you for joining us, Georgie.
Hi there, good morning, good afternoon, everybody. I'm delighted to be here today. Thank you very much for inviting me, and thank you to everybody who's joined us. Just to clarify, I'm funded by the National Institute for Health Research, but I'm actually joining from the School for Social and Community Medicine at the University of Bristol in England, within the Centre for Public Health. And I'm going to talk today about my systematic review, peer-led interventions to prevent tobacco, alcohol, and drug use among young people aged 11 to 21 years. And this was published last year in Addiction. It's an open access publication, so as well as being accessible through health evidence, can also be accessed through the internet. And this is the review team who conducted the review alongside myself, Dr. Sean Harrison, Deborah Caldwell, and Professors Matt Hickman and Rona Campbell, and all of us are based at the University of Bristol in England. So first of all, why are we interested in substance use among young people? Well, adolescence is a critical time period when initiation of substance use commences, and the prevalence of use can increase sharply during this period, and the trajectory of substance use can increase through to young adulthood and can continue into young adulthood and beyond. The age of onset of substance use is actually relatively similar across high-income countries globally, being on average between the age of 16 to 19 years for alcohol and tobacco use, but slightly later, averaging about 18 to 19 years for cannabis use. In the UK and in other parts of the world, so in the US, we've seen overall downward trends in substance use, with the exception of the last couple of years for drug use. But nevertheless, a substantial proportion of young people are using substances, and large surveys show that, for instance, among 15-year-olds, around a quarter have used drugs in the past year, and 8% of 15-year-olds report regular smoking, with just over a third report having ever smoked. Studies also show that around a third, or 34%, have been reported to drink at hazardous levels, and by the age of 17, over half report drinking in the past week. The UK actually ranks relatively high in comparison to other European countries. So in a survey of 36 European countries of 15 to 16-year-olds, the UK was ranked 5th for drug use and also 7th for binge drinking. You can see in this graph the United Kingdom, around just over half, so 52% of 15 to 16-year-olds reported binge drinking or having had 5 or more drinks on one occasion in the past month. And this sort of prevalence isn't unique to the UK. For instance, in Australia, about half of male adolescents have been reported to highlight that they've been binge drinking in the past week, and around a third of females. In the United States, by age 18, around 60% have had a drink, and a third have used cannabis in the past year. So what's the public health importance of substance use? And what are some of the consequences? Well, there are a range of negative consequences of substance use during adolescence, and these can be both short and long term. And I anticipate that you'll be familiar with several of these. So we know that smoking increases the risk of a number of different cancers, cardiovascular disease, stroke, chronic respiratory disease, and ultimately premature death over the long term. And many adults who are heavy smokers commence smoking earlier in adolescence or young adulthood. For alcohol, we know that it increases the risk. Intoxication and heavy drinking can increase the risk of violence, injury, accidents, and sexual risk behavior, increasing the risk of sexually transmitted infections, unwanted pregnancies. And over the longer term, it can increase the risk of a number of different cancers, cardiovascular disease, liver disease, and others. And it's worth noting that in the UK, liver disease is actually the 3rd commonest cause of premature death, and it's the only major cause of death that's increasing year on year. And it bucks the trend among other European countries where the rate of mortality from liver disease is actually coming down, whereas in the UK, the rate of mortality is going up. And lastly, in terms of drug use among young people, this can increase the risk of mental health problems and vehicle risk, and also the risk of dependence later in life. In terms of the global burden, this rises during adolescence and adulthood, and studies have shown that between the ages of 15 to 19, alcohol and drugs together account for 7% of the global health burden, and that's measured in disability-adjusted life years. So that represents a combination of the years of life lost due to disability and early mortality. And by age 20 to 24, alcohol and drugs together are responsible for 10% of the total health burden. And smoking is not included here because the health burden is sort of felt over the longer term. But alcohol alone actually contributes to just over 300,000 deaths among young adults, and approximately 9% of deaths in this age range. So it is a big problem and a public health priority to prevent use and some of the harms associated with it. The global burden is felt where use of these substances is most common. So for tobacco, that's Western Europe and some African countries, and for alcohol, and particularly in Eastern Europe, but also Western Europe, Northern America, and Australasia. And for cannabis, similarly, the burden is felt in the USA, Canada, Australia, New Zealand, and Western Europe. So what do we know about interventions that might prevent use and some of the harms associated with substance use in young people? I'm excluding population-level interventions here, such as sort of policies, pricing interventions, advertising restrictions, that kind of thing. But there's a substantial body of literature around different interventions to target substance use in young people. And very broadly, there's evidence in support of parenting interventions, high-intensity interventions for addressing tobacco use, parent-based interventions for alcohol use, and there's some evidence that these can be effective for drug use as well. In respect of school-based interventions, there's evidence that multi-component programs, or those that use a number of different approaches, such as a curriculum and a family or community component, can be effective for tobacco use. And that some sort of non-specific programs can be effective for alcohol use. So, for instance, those that target some of the social influences on drinking and how young people respond to those. Similarly, those that target some of the social norms and try to sort of correct some of the misperceptions around norms have been shown to be effective for alcohol use. And for drug use, there's evidence from systematic reviews that programs that improve personal and interpersonal skills through sort of goal setting, decision making, and teaching skills to resist peer influences and media influences can be effective. In relation to those that target just individuals, the findings are a bit more mixed. And overall, the body of evidence is very heterogeneous, and there is variation between studies in terms of the participants included, some of the components or approaches, how long the interventions might be implemented for, the outcomes that are measured, and the extent of follow-up. And some reviews have highlighted that there are differential effects, both by the age of the young people, so the stage during adolescence or young adulthood, and the intensity of the program, so for instance, how many sessions might be implemented. And importantly, a number of reviews do highlight that interventions have methodological weaknesses or reporting issues in the resulting reports, and this leads to a risk of bias. So there does remain scope for novel approaches in terms of preventing both substance use and associated harms. So this leads me on to the background and rationale for our review. Part of my research is focused on the role and impact of peers and social networks on alcohol use in young people, and how we might be able to harness the role or influence of young people's friends and peers in some kind of novel intervention. And this has led us to considering peer-based models and whether these might be effective and might be an approach that could be considered. One of the reasons for considering the role of peers and thinking about peer-based interventions is that at this particular stage of the life course, so during adolescence, peers play a prominent role and do sort of influence behaviour. So studies show that an association with substance-using peers or friends that use alcohol, tobacco, or drugs is associated with a young person's own use. For instance, quantitative studies have shown that in early adolescence there's a 6-fold greater likelihood of drinking if you have 4 compared to no drinking peers. And also, for every 10% increase in the number of classmates who drink, individual drinking can increase in likelihood by 4 percentage points. And studies have shown that this can be due to a direct influence of your friends or peers' behaviour, or the fact that a young person may select peers that have the same kind of behaviour. And it could be that one or both of these mechanisms are playing a role. So what are peer-based approaches? What kind of interventions are we talking about? They've been defined as the teaching or sharing of health information, values and behaviours by members of a similar age or status group. And so they can involve the direct delivery of an intervention by young people, facilitation or group work, or delivering scenarios and discussions. Peers can be giving part of the intervention or the entire intervention, and they may be the same age, or they could be older peers from within a school or perhaps a university. They can be implemented in formal settings, so they could be in schools or more informal settings in the community. Can be directly educational, so for instance delivering curricula within schools. Can be more discursive, or can also use a sort of diffusion of messages. So there are a couple of interventions that utilize Rogers' diffusion of innovations theory, which talks about how messages can be transmitted through social networks by particular channels, or for instance through peers and their conversations. And some of the reasons that people have investigated peer-based approaches are that it's been suggested that young people have a greater credibility in presenting health messages or preventive messages. They may learn well from each other. They may have a shared cultural background, similar language around using substances, and actually understand the behaviours. And they may also act as positive role models for young people. And there may be benefits to the peers who deliver the interventions themselves. And so the sorts of things they can do being delivering films, scenarios, role plays, curricula and group work. So what's the evidence base, or what was the evidence base before we did our systematic review around peer-based interventions in terms of health benefit for young people? Well, there were two primary reviews, one of which was systematic, and one of which, published by Malambi and colleagues in 2000, focused on school-based health education. And they highlighted the results of studies that showed a behavioural effect. And out of those 11 studies, 64%, or 7 studies, showed that peers were at least as effective as adults. And 9 out of 11, so about 75%, showed that they were more effective compared to control. In the second review, published by Angela Harden and colleagues in 2001, they identified 64 studies that met their inclusion criteria, so they were looking at peer-delivered health promotion, but slightly broader than our remit in that it included substance use, sexual health, cancer and violence. But they identified 64 studies, but only 12 studies were actually judged to be methodologically sound. And out of those 12, just over half were found to be effective for at least one behavioural outcome, 3 of which were effective in relation to smoking. And 5 studies compared peers to teachers, but they found contradictory results. So 2 studies showed that peers were more effective than teachers, 2 showed that they were equally effective, and 1 showed that neither group were effective. Interestingly, they found that from process evaluations, the young people who participated in peer-led interventions gave very positive feedback about receiving a peer-based intervention, found it more fun, felt that they communicated messages really well, it was more relaxed. And so they had a very positive view about them. But overall, both reviews highlighted that really the evidence wasn't clear at that stage, or insufficiently clear to justify wider implementation of these interventions. And one of the reasons for that was that many of the studies had a lack of methodological rigour, so had not highlighted data about or information about comparator groups, were at risk of bias, and had high levels of attrition, so loss of participants from the study as it moved forward. Importantly as well, neither of the studies conducted a meta-analysis, so there was no summary estimate of effect of these interventions. And because they were published quite a while ago, there's a lack of recent evidence and a need to actually update the reviews. So the aim of our systematic review is to identify and review the latest evidence around peer-based interventions focused on tobacco, alcohol and drug use, and to look at interventions that targeted young people throughout adolescence and young adulthood, so both in secondary education and also tertiary education, so colleges and universities. We conducted our searches in a number of different databases, as well as checking the grey literature, and we used a mixture of both MESH and text words in our comprehensive search. So in terms of inclusion and exclusion criteria, we included only randomized controlled trials so that we had the most robust evidence. Trials had to have at least 6 weeks of follow-up. Over half had to be aged 11 to 21 years, and peers had to be involved in a substantial component of the delivery of the intervention. We excluded studies that were clinical or brief interventions, that were multi-component interventions, so that had several different approaches, such as school, community, and family, for instance, and those that targeted prescription or body-enhancing drugs rather than illicit drugs. And we had no language or geographical restrictions on the studies that were included. So here's our PICO. So our participants were young people aged 11 to 21. Our intervention was any that targeted alcohol, tobacco, and or drug use. It had to actually target the use of those substances as an aim of the intervention rather than just measuring use of those substances. And it could be an intervention in any setting. Our comparator was usual practice or no intervention, but we also included studies where peer-led intervention was compared to teacher, professional, or adult-led programs. And our outcomes were tobacco use, and that included smokeless tobacco, alcohol use, and drug use, and that's the list of drugs that were included in our search. Although all of the studies that we included actually measured measured cannabis use as an outcome. Just one study measured cannabis and cocaine use. So this slide summarizes our methodology. We screened titles and abstracts in duplicate, and we also extracted data from full text in duplicate. We extracted odds ratios from studies, and where this wasn't possible, we calculated them using the raw data or converted continuous data to odds ratios. And we used the tool from the Cochrane Handbook to assess risk of bias, and we did this in duplicate. We had to adjust a number of studies for clustering. So several of the studies were school-based, and so the schools had been randomized as units. However, because the data had been analyzed at the individual level, this can give rise to a problem where the sample size is effectively too large, because individuals within clusters, so within schools, will be more similar to each other, and therefore they're no longer independent. And so we have to adjust to reduce the effective sample size, otherwise you can draw a sort of false positive conclusion. So we used an intracluster correlation coefficient from one of the studies that was included, and this is an estimate of variability within and between the clusters or schools. And we use this to adjust the data appropriately. And because we'd used an intracluster correlation coefficient from one study that reported it, we included a sensitivity analysis where we used different values, and this didn't affect the results at all. We used a random effects model to analyze the data in our mesh analysis. So this assumes that there's a distribution of intervention effects across studies rather than measuring the same effect, although we did include a fixed effects analysis as a sensitivity analysis, and again the results are similar. We assess heterogeneity or the variability of intervention effects across studies using the I-squared statistic and chi-squared test. And we examine heterogeneity and the possibility of reporting bias using a funnel plot and Omega test. So this was only possible for studies that targeted smoking because we had sufficient studies in order to do this. So this shows the flow diagram of studies in our review. So we identified 1,387 titles, and this came down to 17 unique studies from 25 different papers, 14 of which we could include in the quantitative synthesis. And in terms of the studies that were included in our review, over half were conducted in the 80s and 90s. Again, over half, or 59%, were conducted in the USA, and a third of studies were conducted in Europe. And the same proportion, 59%, targeted young people aged 12 to 14, so focusing on that sort of early adolescence period. The large majority were school-based studies, so 82% of them were based in schools, and just over half targeted tobacco, with a quarter of studies targeting all three of the substances together. In terms of the sorts of things the studies or the interventions covered, there was a range of different parameters or components. So some focused on refusal techniques, how to refuse the use of substances, looking at consequences of using substances, and also perception of norms within peer groups and society and realigning some of those. Some used videos to show scenarios and to discuss those. Some focused on communication skills and having sort of positive, effective communication conversation. Some used scenarios and role play, focused on advertising and some of the influences of that, and resisting peer pressure and also resisting wider influences. And some studies would incorporate many of those different approaches in the same study. And there was some variability in the interventions included, so some took place over a number of weeks and some over years, so there might be a smaller number of sessions or an average number of sessions, but they might take place over 3 school years, for instance. And the range in number of sessions taught or held was 2 to 36. Some were based on an academic curriculum, some just informal conversations. And peers were the same age as participants and also older in some instances. And most of the time, teachers and facilitators were present alongside peers or in the same intervention. And so peers, as I've mentioned, could undertake a number of different components of intervention. So they might lead boosters, group sessions, role plays, conversations. In some interventions, they were selected by their classmates, and some were recruited by teachers, and in a smaller number, they volunteered. And in terms of the training for peers, this is quite variable. So in terms of the least amount of training was 1 hour training plus a manual that they could use. And the most intensive was a 9-month course, followed by a 7-day intensive course. And some had somewhere in between with sort of 4 hours of training or several hours to prepare them for their role in the intervention. So this is our summary of the risk of bias of the included studies. In red is shown where there was judged to be a high risk of bias, and the yellow shows where it was unclear, where there was insufficient detail or information provided in the papers, and green shows where there was a judgment of low risk of bias. And you can see standing out that there was a high risk of bias resulting from a lack of blinding. Of course, it's not possible in these sorts of interventions, but it does mean that they may be at high risk of bias as a result of a lack of blinding. And there was insufficient information in many of the papers to assess whether there was risk of bias as a result of how studies generated a sequence for randomization, how they concealed allocation of participants, and how outcomes were assessed, whether there was blinding around the assessment of outcomes, so substance use. And there was also unclear risk of bias in a number of studies around reporting of outcomes in the papers. So this leads us on to our first finding around tobacco use. So for this analysis, we had just over 13,700 participants from 220 schools. And you can see here the forest plot, which shows down the left-hand side the authors of the study paper and the date that the study was implemented or that the first paper was published, if that hadn't been reported. And you can see the effect estimate of individual studies shown by the small black dots. And the box around that shows the weight of the study in the meta-analysis, with the line representing the 95% confidence interval, which is essentially the range of values within which we're reasonably confident that the true intervention effect lies. And then down the right-hand side, you can see the point estimate and 95% confidence interval listed. And our summary effect measure, which is our sort of best guess of the effect of these interventions targeting tobacco use, was an odds ratio of 0.78, so that reflects a 22% reduction in the odds of tobacco use associated with peer-based interventions. And we had a statistically significant effect with a p-value of 0.04. And here our 95% confidence interval of 0.62 to 0.99 doesn't cross the null value of 1, and also shows us that we can be reasonably confident that the true intervention effect could be anywhere between a 38% reduction or a 1% reduction in the odds of smoking. We found moderate heterogeneity here. Our I-squared value is 41%. And this shows the variability in the intervention effects being measured. And we find this when studies differ with respect to participants or outcomes or perhaps study design. And so this shows the proportion of variability in the effect estimates that's due to heterogeneity rather than chance. And this shows us that it was moderate for these studies. For alcohol, we found fewer studies that targeted this outcome. So for this analysis, we had just under 1,700 participants from 66 schools and 1 university. And our overall effect estimate was an odds ratio of 0.8, so demonstrating that peer-based interventions might be associated with a 20% reduction in the odds of alcohol use. And again, we saw weak evidence of a statistically significant effect here with a p-value of 0.04 and lower heterogeneity among these studies. However, we had fewer participants in this analysis, and it's worth noting that the meta-analysis just of unadjusted estimates gave a null effect. And when we conducted a sensitivity analysis, so we excluded one study for which assumptions had been made to include it in the meta-analysis, we had a null effect. This first plot summarizes our findings regarding cannabis use. So again, fewer studies were identified that targeted cannabis use. So we had just under 1,000 participants in 38 different schools. But again, we saw a statistically significant effect. So the odds ratio was 0.7, highlighting that a 30% reduction in the odds of cannabis use for these interventions, and limited heterogeneity here. Importantly, in 2 of the included studies, adverse effects of the peer-led intervention were identified, where tobacco or alcohol use was actually higher among high-risk groups in the intervention. So for one of these studies, where peer leaders were identified via nominations from their classmates about who would be seen as good leaders, there was actually higher use amongst those that had existing networks of peers who used substances. And in the second study, a higher prevalence of smoking and pro-smoking attitudes was found among those in the peer-led arm of the intervention who were baseline smokers, so who were smoking at the beginning of the study. And it was suggested that actually this might be a result of the fact that the norms within those social groups would be in favour of using substances, and so in order to heed the message of the intervention, you'd have to step outside from the norms of the social group and risk social isolation, and therefore that makes it less likely. And this process has been termed deviancy training, where involvement with higher risk peers can actually increase your own substance use or the risk of using substances. So just to summarise our study, what we found, some of the strengths are that we used multiple different databases to identify studies. We included randomized controlled trials, so the most robust evidence in terms of the evidence hierarchy. And we included interventions that looked at 3 different behaviours, and we were able to quantify for the first time a summary effect of these sorts of interventions. However, the evidence that we identified was of low quality and was at risk of bias. We also had insufficient data to compare the effect across different risk groups, or by gender or ethnicity or socioeconomic status. And importantly, as just over half of our interventions were conducted in the 1980s and 90s, they would be relevant to the cultural norms and prevalence and social norms of those decades, but might perhaps be less relevant to the current day, where the prevalence has changed, there's an increasing role in social media, and some of the cultural norms may be slightly different. So just in summary, we did corroborate and strengthen existing evidence around peer-based interventions, and we identified that they can reduce tobacco, alcohol, and possibly cannabis use in young people, potentially because peers are embedded in social groups, they share social, cultural norms and backgrounds with young people. They may have greater credibility, and there may also be positive or possible benefits to the peer leaders themselves by being involved in these sorts of interventions. And so there is scope for the more extensive trial and implementation of peer-led interventions. For instance, school-based curricula for tobacco were effective, and there are a number of studies based on this model, and so that might be a particular area to focus on for the trial of further studies. But overall, there's some caution around these findings. The evidence was of poor quality, and there is the potential for adverse consequences. So any further studies that assess the effectiveness of peer-based interventions need to take into account peer norms, cultural and social norms, and think about how messages are targeted in different risk groups, accounting for some of these norms and wider influences on behaviour. But there does remain a need for robust, very rigorously conducted studies that have sufficient follow-up, and also that include process evaluation, so that it can be very clear if the intervention is effective, what might be responsible or which components might be particularly effective and what participants felt about the intervention, but also if the intervention isn't effective, what might be some of the reasons for that and things that could be changed or altered in further investigations. So that brings me to the end of my contribution. I'd just like to acknowledge some of the funders of the study though, that enable it to happen. So that'd be the National Institute for Health Research, the Wellcome Trust, the Medical Research Council, and also Decipher, which is a collaboration of the universities of Bristol, Swansea and Cardiff in the UK, and one of the UK clinical research collaborations, Public Health Research Centres of Excellence, and that supported this study as well. So I'm very happy to take any questions. I've also included my email address if anybody would like to contact me and ask any questions following the webinar. Thank you very much.
Thank you very much, Georgie. That was a really great presentation and overview of how you did your systematic review and what you found. So that was really great. We're very happy to have you present on your systematic review. So thank you to everyone who's joined with us. We'll now be opening up the session for Q&A or any comments that you might have. So please post any questions or comments in the chat or Q&A section on WebEx, and I'm happy to relay any of your questions or comments to Georgie to respond to during our session. So I don't see too many questions or comments coming through right now. So one that we had during our session, Georgie, was from Claire, and she's wondering if you can maybe comment a little bit further on the inclusion criteria that you used for included studies. Claire just had a comment on the fact that a few of the included studies were from the 80s and 90s and how some of the cultural norms, including the differences between being a teenager in the 80s and 90s and being a teenager now, and also how tobacco regulations and laws have changed recently. So how might these aspects affect the findings of the systematic review? If you can comment on that.
Yeah, I think that's really important actually, because the cultural norms and the prevalence of use was so different in the 1980s and 90s. So the trend has very much been downwards in terms of tobacco use, and the prevalence is very much lower, certainly in the UK, I think also the US, and I'm afraid I don't know too much about other countries. But yeah, so that will make a difference, and it somewhat limits the applicability or generalizability of those studies. What does remain useful, though, is thinking about the nature of different components and whether those can be applied to the current day. So we were particularly looking from this review to think about certain models that had been effective and thinking about certain approaches that might be able to be adapted to the current time. So not necessarily directly translating a particular approach, but thinking, okay, this might have been effective in that at that time. Let's think about how we might be able to adapt it now. And I think certainly tobacco use now is much lower in adolescents, but some of those approaches might be effective or might have components that are effective for alcohol or drug use and could be applied to those where the prevalence might be slightly higher now. So I think that was the aim, really. But I think, yes, it does limit the generalizability somewhat. And we didn't necessarily expect that the proportion of those interventions from that time would be as high. So certainly I was aware that there was a greater focus or interest in peer-led interventions in the 80s and 90s than has been evident in the last decade or so. But it wasn't clear that there would be fewer in the last few years. So, yeah.
That's great. Thank you very much for commenting a bit further on that. That's really helpful. So we'll move along. We have another question. Does reporting bias on the studied outcomes apply differently for the product? So that is alcohol, tobacco, cannabis, or other drugs.
So in terms of, I'll answer it in terms of our study, but I'm not sure whether the question might be about the studies included. But we found we could only assess publication bias, the potential for publication bias for the studies that targeted tobacco use. And we did find from our funnel plot we had a few small negative studies. So that could reflect a publication bias or issues around poor methodological design and risk of bias in those studies that were included. However, the test does have low power and it should be interpreted with a bit of caution because we only had 10 studies included. So in terms of the tobacco findings, there is the potential that there was some publication bias, but there's some caution around that. And it is possible that studies that have positive findings are more likely to be published and cited, etc. I hope that answers the question.
That's great. Maybe we can get another comment from Yuri, who posed that question, to elaborate a little bit more, but that's great. We have another question from Mark Andrew, who's asking if he understands correctly, it's not a good idea to have high-risk groups nominate a candidate to be a peer leader.
I think there's just a risk that there is a risk. I mean, it was identified in 2 out of the 17 studies, so relatively, well, I can't comment really on whether that's a low proportion or not, but there is the possibility that individuals that commence engagement with higher risk groups or individuals that are already at high risk but engage with high risk groups may increase their substance use if the sorts of messages that are communicated endorse substance use, and there is that potential. So I think there has to be some caution, in my opinion, around how those messages are targeted and whether you might think about targeting higher risk groups slightly differently. It's something to be quite cautious about, I think, and has been identified in other studies where higher risk groups can have this effect on others. Whether that means that high risk groups shouldn't select individuals, I don't know if that would be the case, but it's something to be cautious about when designing or implementing interventions of this kind, I think.
That's great. Thank you, Georgie. We have another question here, which kind of maybe if you're familiar with the current political environment in Canada and the Liberal government, which is pushing to legalize cannabis in Canada. So we have a question from a user who's asking, what do you anticipate the effect of legalization of cannabis age of 21 years and over will have on youth cannabis use?
I have to say I'm not familiar with the effects of legalization of different substances on the prevalence of use. There's a potential for, I suspect where legalization or decriminalization has occurred in other parts of the globe, there may be effects on perhaps reduction in harms. I don't know enough about the impact of legalization to be able to comment with sufficient clarity and effectiveness on that, I don't think, I'm afraid.
Okay, that's great, thanks, and we'll leave it at that for now, given the background. So we have another question here that's saying, if you can comment, we have a user who's a little bit surprised with your conclusions were as strongly supportive of the potential for this intervention given the quality of the studies and the confidence interval around the effect, not approaching 1, but it's almost approaching. So wondering if you can maybe comment on your conclusions given the findings.
Yeah, well, I mean, overall we found evidence of an effect and it was beneficial, so the direction was favouring the intervention. And the summary effect estimates with the fixed and random effects model were around 0.8, 0.75, 0.8. So that still suggests that there may be a benefit, and a reduction of 20% in the odds may have clinical importance. So hence the conclusions, but there's essentially a note of caution around it in that some of the studies were at unclear risk of bias or perhaps inadequate reporting. So it's really saying, well, this is what we found. It shows that the results favour the intervention, but we do have to be somewhat cautious. But there were certain approaches where identified where the studies were very robust that show potential. So, for instance, there was one study included which used the diffusion of innovations theory that was conducted in the UK, where young people had informal conversations with members of their year group. They were sort of peer leaders who were nominated by members of their year group, and they sort of just had informal conversations and diffused messages, and that was found to be effective, and that was a very large randomized controlled trial here in the UK that was judged to be at low risk of bias. And there were other studies that were effective too, so I think it wasn't a sort of entirely bad picture, but it is a note of caution around the findings. Yes, it is, yeah.
So that's great. Thanks for commenting on that. And we know that you used a variety of statistical models to show that, so that's great that we have some feedback. So we have another question coming in that's saying, do you think, given the scarcity of recent studies on this topic, could be due to the findings, so the size of the effect and the significance of the studies that were performed in the 80s and 90s?
Yes, I think the conclusions of the two reviews I mentioned at the beginning were quite tentative and sort of highlighted that there wasn't enough evidence at that time. And I think they slightly went out of favour in the sort of later years or more latter years. So I think there was a greater focus on these interventions, and then as the evidence was equivocal, and I think some of the studies lacked methodological rigour, they did slightly go out of favour. And so I think that might be why there's less evidence from recent years. But I think there is potential or scope for the continued research or the development of research that uses really robust methods and robust randomized controlled trials to assess whether these might be effective. So, yeah. And also, just to come back to the question that was asked before, I suppose essentially what we're saying is really this is the best evidence or the best estimate effect we can have at this point, using sort of best methods we have and with the evidence that we can identify. So it's really just saying this is our best estimate of effect.
For sure, that's great, thank you. So we have another question coming in that's saying, is the magnitude of influence higher in high-risk settings or low-risk settings? And in terms of counteracting peer-based negative influences, and how is that accounted or adjusted for?
We weren't actually able to assess with the data we had whether the effect was stronger among higher risk groups or lower risk groups, because we just didn't have sufficient data to assess that or to conduct any subgroup analysis, unfortunately. It's a really interesting question. It would be really good to know, but we just weren't able to do that, unfortunately.
That's great, thank you. So we have another question about the peer leaders, and maybe you can comment. So we have two questions here. If you can define what peer is, and if you have any information specific to the peer leaders. So that is, are they generally academic, popular, or would there be a mix of peer leaders which include those who have or have used, are high risk for youth, mental health issues, integrated into the group of the peer leader?
Yeah, that's an interesting question. So in terms of defining peer, it's essentially another young person, really. It can be a friend or a classmate or somebody who's in the same sort of age group. It's sort of quite a loose definition, really, that I would give to it. In terms of the peer leaders themselves, I know one of the systematic reviews I mentioned that was published in 2001, it did identify that peer leaders tended to be female more frequently. And I think there is a tendency that if teachers nominate peers, one of the reasons we looked into how they were nominated, if teachers nominate peers, there is a tendency that they might choose those that are more popular, more academic, more sort of less likely to necessarily use substances, perhaps. And that's why I think quite a few of the studies actually chose the peer leaders by having young people nominate themselves. And I think by doing that, it perhaps increases the likelihood that they might be relevant. So in 2 of the studies, they asked who you thought might be good leaders, and it wasn't necessarily who was most popular, but it's who they thought could lead. And certainly in at least one of the studies, they could be smokers, and they didn't have to abstain from the use of the substances. But I'm not entirely clear, and can't be entirely clear from the study reports themselves, how many of those peer leaders would have been from higher risk groups. And I think there is a potential that they would be those that are more academic and more popular. And I think certainly previous studies show they may be more likely to be female rather than male.
That's great. It's good to hear the feedback on who these peers actually were in the interventions. So we have a few more questions coming in, which is great. And in the meantime, I will move the slides along to a few in-session poll questions that we have here from Health Evidence. So now that you've heard the evidence from Georgie, if you can comment on your opinion of peer-led interventions reduce odds of youth tobacco smoking, alcohol use, and cannabis use. So it'd be interesting to hear if opinions have changed as a result of hearing the findings. So we'll leave that poll question open for a few moments, and remember to hit submit at the bottom once you respond. So that's great to those who are responding. We're seeing a few people who are still in agreement and a few who still strongly agree, and a select few are neutral. So just not too much, but a slight change in opinions as a result of sharing the findings. And just our last polling question of the day, if we can comment on the information today that was presented, if it was helpful to you. So whether that's in decision-making, program, or policy decisions. So thank you to those who are responding. And in the meantime, Georgie, we have a couple more questions. So we have one from Dan who's wondering if you can comment on the commonalities between programs that had a positive impact.
Yes, so those that were the more effective programs tended to focus on social skills, thinking about peer norms, and perhaps readjusting people's perception of norms, because we know that in some cases young people can overestimate what they perceive norms to be in their groups. Also, those that thought about sort of positive peer relationships and behavioural norms tended to be more effective. And yes, I'd say that was probably the main thing, really. I mean, there were quite a variable mix of interventions, but several did use as a basis of them the social influences model, and so that's about trying to encourage young people to resist sort of wider social influences and peer influences by developing those sort of skills and personal skills and communication skills. And I think that was something that was perhaps a sort of common theme of those more effective interventions.
That's great, thank you. And we have another question here from Dan who's following up and asking, if the data indicates if the interventions that focus on relationships versus drug information have a great impact?
That's a slightly tricky question I'm not sure I can answer, as we didn't sort of look specifically at that in terms of the different studies. Many of them included a sort of educational component and also thought about sort of peer relationships, peer norms, or peer influences, and so distilling that down might not really be possible from the way the studies were conducted, actually.
That's great, thanks. I know it's hard to include all analysis in one systematic review, but there's a lot, so great questions. And we just have our final polling question up, if you can answer before those who are taking off for the afternoon, which is what are your next steps? And we remind you that the full text systematic review is available on Health Evidence. as well as the quality assessment for the review. If you are also planning on considering using the evidence, and if you are planning on telling a colleague about the evidence. So we just had one last question that I think we might have missed earlier that we can fit in today, which is, in your opinion, as of 2016, what are some of the specific ways that seem to be most effective in influencing behavior change related to tobacco, alcohol, and drug use in
specific ways of influencing behaviour change? In terms of the evidence, I think it's possibly strongest for those really sort of population-level interventions. So for smoking, things like public bans, pricing, and pricing's a big one, limiting availability. So those sorts of interventions do have good evidence. In terms of each of the substances, and thinking about sort of lower level intervention, so to speak, so more sort of family and school-based. I'm most familiar with alcohol out of the three substances, and parenting interventions have sort of small but consistent effects in terms of reducing alcohol use. So that would be things around sort of encouraging parents to communicate with young people around drinking, setting rules, monitoring, providing advice, and that sort of thing. There are some school-based interventions that work, but I think the systematic review evidence might be strongest for parenting interventions for alcohol. And in terms of tobacco, I think the multi-component, the sort of multiple approaches through schools does seem to be effective in changing behaviour. But I think the best evidence is around the population-level approaches.
That's great, thank you. So we just have one last final question, and again, this might be out of your scope from what you looked at in your systematic review, but perhaps you can comment on the last question here, which is, what about critical thinking skills regarding tobacco and alcohol advertising and how it can sometimes appear manipulation?
Yes, so advertising was addressed in some of the interventions. So they had sessions or components that did think about the influences of advertising. From our review, we didn't go far enough in, I don't think we're able to really think about critical thinking skills around advertising and some of the impacts of it. I think there's likely to be evidence around interventions that limit advertising or affect the ability or timing of advertising, etc. But I'm not familiar directly with that evidence, I'm afraid, so I don't know exactly what that impact might be.
For sure, and that's great. And thank you very much for answering all the questions today. We know it's difficult to fit in all analysis in one systematic review, but you and your review group certainly looked at a lot of data from these interventions, so that's great. With that, I will close the presentation today, and just a reminder that Georgie graciously included her email, so we'll have that again posted in the chat section in case anyone has any further questions for our presenter today. Georgie, thank you very much for your great presentation today and overview of your systematic review process and all of the different statistical analyses that you did. It was definitely a lot of work, and we thank you for that. And just a reminder to all attendees that we will be posting the audio recording and the slides on our SlideShare and YouTube account, and again, those resources will be included in the chat section. So if you have any further questions for health evidence, we also have our email included. So I'll leave it to you, Georgie, if you have any final notes for our attendees today.
Just to say thank you to everybody for listening and joining. It's been a really great webinar, so thank you.
Thank you very much, and we're very pleased to have you. So thank you to those who joined us today and stuck around for the extra couple minutes at the end. Thank you, and have a great afternoon.